Whereas if there's no vaginal bleeding, sublingual and vagina about the same. But culturally, from patient satisfaction, it still might be easier to put it under your tongue than in the vagina. Next, please. Let's go to the next one. Okay. So now some clinical applications. How does this all relate to what we're actually doing? And I'll try and cover some things kind of quickly in the next little while. For those of you who are thinking about being an obstetrician gynecologist, this is pretty much all there is to know. We can make just about any diagnosis from one of these three things. Pain, pregnancy, bleeding. That's all there is. And in most cases where you have pain, pregnancy, and bleeding, we're either talking about labor or incomplete abortion, which is where we live sort of programmatically in some of our PSI programs right now. Next. Okay, so let's just talk about some of the uses in early pregnancy. We may skip ahead and do the postpartum after that. Okay, so how does misoprostol help us out in this setting? Let's have the next one. There are two concepts that we need to, it's important for us to differentiate. One is what we sort of call early pregnancy failure, and the other one is called incomplete abortion. Early pregnancy failure is generally defined as a pregnancy which has failed, it's withered on the vine, but has not been expelled, or the body hasn't recognized this yet, and the pregnancy is still there, even if the woman has no longer any signs and symptoms of pregnancy, or it hasn't grown in 4 to 6 weeks. And this is what we call early pregnancy failure, sometimes called missed abortion, meaning that we missed the event, there's been no signs and symptoms, but actually it's a miscarriage. Or incomplete abortion, in which the pregnancy has passed at least partially, and some residual clots remain. And this is almost always symptomatic, and this is very similar to the scenario we see in most developing countries. The real difference in developing countries is that in many places we don't know, and we can't know for a variety of reasons, whether this is an actual spontaneous miscarriage that the woman has suffered, or whether she went someplace first and induced or provoked a miscarriage, basically started an abortion process, and now has presented symptomatically with signs and symptoms of incomplete abortion. That's a very common scenario in settings where abortion is illegal. And these are the people who come in bleeding, sometimes infected, and in need of help. Next, please. How can you manage these things? Well, you can do nothing. You can just wait for nature to take its course. Certainly you can do that in the first instance, but in the second instance, it's unwise because they're already bleeding, they're going to continue to bleed, or they're going to get infected, or whatever infection they have is going to get worse. So you pretty much have to do something. We can do this surgically with what's traditionally called dusting and cleaning, dilatation and curettage, or now it's generally done with a vacuum device, often a handheld vacuum device, manual vacuum aspiration, or we can do this medically with misoprostol alone or mifepristone and misoprostol. Next. Expectant management works, and again, in the setting where you have a very spontaneous, a very clean setting, especially early pregnancy failure, it'll work, just about as well as giving a drug, but you have to be patient. And especially in the United States, people aren't too patient. They want something to happen now. But it's not necessarily dangerous to just wait and do nothing. Next. Keep going. Now there's a lot of data here that when I talk with more clinical audiences I would share, but what I'm going to skip ahead probably and say is that when we give misoprostol for missed abortion, so that's that first indication where nothing has passed yet, you can expect a success rate of about 83%, 75 to 85%, something like that. And when we say success, we mean that the drug will work by itself. There's no need for surgery. However, let's go ahead a few slides. Let's just keep going. Keep going. Keep going. Keep going. Keep going. Yeah. In the setting where this is an ultrasound picture, where a lot of the pregnancy is already passed, we just don't know what the initial incident was. Was it provoked or was it truly spontaneous? You sometimes see a picture like this in ultrasound. Have any of you ever seen an ultrasound picture of a pregnancy before? on Mad Men or whatever, who's ever got a problem right now? Well, usually, you see a big sac. You see a big sort of balloon inside the uterus. But this is what's left over, commonly called just schmutz, inside the uterus. And this needs to be evacuated. Because if this stays here, this is not viable. This is sort of dead tissue. It's going to eventually cause an infection. So we want this to be expelled either by uterine contractions or by us putting in an instrument. So let's go to the next one. And I don't know if you can see it now, but that thick line that you saw before, that all that schmutz is now sort of this thin line here, and that's the result of misoprostol. It contracts the uterus like squeezing toothpaste out of a tube. Next. And now this line is then even thinner. This is artifact. This is the line right there that we're really interested in. Next. Let's keep going. I just want to get to the part where we talk about incomplete abortion. So, in the settings in which we work, we have a much more, a setting like this is much more common, where we have people present clinically with incomplete abortion after doing whatever we don't know. And in this case, we wanted to find out whether misoprostol was going to be useful for management of incomplete abortion by nurses, no doctors involved, by nurses, and whether it would be acceptable and effective to both the nurses and the patients, and whether it would be effective. Next, please.